Bismillah ar-Rahman ar-Rahim. I welcome you all from Fauji Foundation, Cardiac Center of Excellence. The topic today is hurdles in Class 3 angina with CTO and triple bifurcation, including a left main stem. This is our faculty, head of department by Major General Suhail Aziz Saab. And I'm Dr. Wajahat Lodhi, and I'll be presenting this case to you today. So we have an 87-year-old octogenarian, very frail and irritable lady who's hypertensive, pre-diabetic with central chest pain, radiating back and epigastrium associated with nausea and vomiting. She presented with vitals of 100 by 60 blood pressure, respiratory rate 18, afebrile, a normal physical exam except that she was frail and very elderly. ECG showed and sinus bradycardia with a heart rate of 48, Q waves in the inferior leads with T wave inversions in the 2, 3, AVF, and T waves in the V4 to V6. Investigations were positive for a troponin I, which was 4.67. A 2D echo showed an EF of 40% with the regional wall motion abnormalities in the inferior wall in the septum. So considering the patient's irritability and procedural complexity, a coronary angiogram was planned with a high-risk consent and anesthesia cover was sought. And this is the first hurdle that we encountered. The radial artery was punctured, the flow was good, but for some reason we were having trouble with wire progression of the jade wire. And we decided to go for the right ulnar at the same time. We wanted to preserve the femoral, and the left radial ulnar approach was not feasible because the patient was very irritable. We could not access that. This is the second hurdle from the ulnar. We were going and we ended up having to encounter an ulnar loop for which a Truma wire was taken, and we tried to straighten the bend and then progress with the angiogram. So this is the LO-caudal view that shows there's an osteal left main, there's osteal LAD disease with the circumflex having mid and osteal lesion, and there's a large OM that's also got an osteal disease. The ariocaudal simply clarifying the lesions, and we can see there's LAD also has an osteal critical lesion, and the tapering of the LAD. Epicranial view shows the cross-filling of the RCA, which probably is, we'll find out later, is a totally occluded segment, and the RAO also shows the cross-filling of the RCA. RAO is a totally occluded segment from the mid-course. It was being cross-filled from the left system. So this was the patient's syntax score. It came out to be 34. She was a candidate for CABG. Her syntax score 2 again showed that her PCI 4-year mortality was 40%, and her CABG 4-year mortality was 14.2%, again favoring CABG, and her risk score for isolated CABG was about 16%. So what should we do? Again, an 87-year-old, frail, irritable lady, diabetic, hypertensive, CCS3, EF40, there's a left main, there's a CTO RCA, and there's a bifurcating lesion of the LAD, ostium, and circ, and there are 2 lesions in the LAD mid and circumflex involving the OM. So there's 3 bifurcating lesions, and there's a totally occluded RCA. So what we did, we sought cardiac surgical opinion, and the cardiac surgeon at that time advised medical treatment and deemed her unfit for CABG considering her frailty. So we proceeded with opening the CTO first. This is a caudal view. We crossed with an over-the-wire balloon using the Pilot 200, and we were successful in crossing the lesion. Again, we proceeded with sequential ballooning of the segment, trying to open the vessel bit by bit. Then the Pilot 200 was taken out using the blowout technique, and we gave a local dye injection to see if we were actually in the true lumen or not. We would then exchange to a workhouse wire. The workhouse in this case was a run-through wire. And then we just gave the result post-ballooning, and then sequential pre-dilations with a 2 into 20 millimeter balloon were done. We deployed the stent, and the result is there. We were happy with this result, so we just stopped here. The patient was then shifted back to the CCU with the 5 days of IV normal saline hydration. We let her recover. We give her time to settle her symptoms. Despite being on guideline-directed medical therapy, patient was having on and off angina symptoms, though of reduced severity, but symptoms nonetheless. So what do we do? Should we go for complete revascularization and fix the left system as well? We again went in for an angiogram. The right system was restudied. It showed patent stents, good flow, and we proceeded with going on with a revascularization of the left system. We decided that we go from a 7 French sheathless approach, which is being demonstrated here. And this is how a sheathless approach looks on a fluoro. There's a balloon tipped, slightly inflated, just snugly fit into the tip of the guide, and then you can just advance it from the femoral. Epicranial view, we proceeded with the LAD and diagonal wire. We used the run-through wire. We've upon wiring the diagonal, we proceeded with pre-dilating the lesion with a 2 into 15 millimeter balloon, and we then stent deployed with a 2.25 18 millimeter mid-LAT stent. Then we went on to fix the circ OM lesion, and we then deployed a 2.5 into 31 millimeter circ to OM stent, and this was the result post-stenting. Now we decided that the OM1 branch is something that we should wire since the wires are open, so we just proceeded with wiring that OM1 branch. And in AP caudal view, we're deploying the LMS to LCX stent measuring 3 into 23 millimeters. Here we can see that there's a balloon in the left main to LAD that we will use in the future to crush the stent, and there is also a NC ballooning of the LMS to LCX stent. Now we're using the crushing technique. We're crushing the left main stem to circ stent with a 3 into 15 millimeter balloon. Then we proceeded with a pot with a 4 into 10 millimeters. Again, we're rewiring the left main to circumflex as our wire has now jailed, and we're trying to open the struts at the same time. The LAO caudal view is showing the opening of the struts at this moment of time with a 2 into 15 millimeter balloon. Again, we're pre-dilating the left main to LAD with a 315. We're pre-dilating the left main to circ with a 315, and then we'll do the first kissing balloon inflation. Apricranial view, we proceeded with stenting the left main to LAD with a 3 into 38 millimeter stent, and this is what we are showing in the next picture is the deployment of the stent, LMS to LAD. And then we again did a pot with a 4 into 10. The important step here is that while we were doing pot, we slightly disengage the catheter, we give a sinus injection, and then go up on the inflation. We rewired the circ again, and so that we maintain patency, and then opening the LMS to LAD struts again, so that maneuverability of balloons and further stunts is easier. Again, now we're going for our second kiss, so we're going to post-dilate the left main to circ, we're going to post-dilate our left main to LAD, and then it's going to be a second or the final kiss, and that will complete our DK crush. We provided with the last pot. It was a operator call. They wanted to do a final pot just to be sure. Again, disengagement of the catheter. We're in the sinus. We give an inflation, so we're comfortable with the 4 into 15. This was the final result, and we're happy up till here, and everything is good. We just proceeded to check for bladder indentation, since for rule out any retroperitoneal hematoma, and at the same time we took a contrast injection of the excess site so that we know that we don't have any perfs in the excess or anything like that. Now we're withdrawing the sheathless catheter. We withdraw it, and we just put the sheath back on the guiding wires, and the sheath goes in back. We maintain hemostasis, and then we're comfortable. So just thank you for your time, and thank you for your attention. The patient is doing well, and she's happy, and we've discharged her 2 days back. Thank you.